in the chat box. But with no further ado, I'm going to pass it over to Calvin Roberson as he will begin our presentation. Calvin.
Thank you so much. So glad to be here. One of the other things I want to know, I also sit on the board of directors for the Indiana Statewide Prevention Network, and so I'm pleased to be here, also representing a volunteer in the charge. So today we're looking at exploring culture and the prevention of suicide. Go ahead and click it, Dave. We're just going to provide an overview, give some trend statistics, look at some risk and protective factors, and then we're getting to the discussion. We just want to make sure we laid the groundwork for this discussion. I think, you know, when we look at suicide, particularly in minority communities, there is always a different slant of view of just mental health and emotional health that comes out in how we seek services, how we seek help, how we receive services, and how we receive help. And so some of the literature highlights that. So here in this particular instance, we pulled this out because this is something that's very common that we hear in a lot of different groups. African-American community, there's a tendency to label suicide and mental health condition as crazy or evidence that you aren't praying enough. And we know that spirituality is a undercurrent for many minority groups that influences whether or not they engage or even identify something as a mental or emotional health issue. That spirituality sometimes can for some of the forward progress towards just getting help. People in this culture, as well as Hispanic, Asian, and American Indians, are less likely to acknowledge the possibility of having a health condition or seek mental health service. Or as some commentators and academics have said, suicide is seen as a white thing. And so there is this pervasive thought that certain mental conditions, particularly suicide, are relegated to cultural groups outside of minorities, but not minorities themselves. And I know when I was growing up, we had cousins, uncles that we would say, you know, Uncle JoJo, ain't nothing wrong with him. And we would dismiss mental, emotional issues because of our cultural context. So I think the literature speaks to that. But also, I think equally as important is this whole concept is that when you look at Black, Brown, and American Indian communities, oftentimes suicide is just misclassified for a variety of different reasons. And so it's not just a failure within the cultural group to acknowledge it, but even within professionals, particularly coroners who are making decisions about the cause of death, it is being misclassified and not captured. And so I think that's something else that's fundamentally important for us to know, because the rates are depressed. The accuracy is not existent because of this misclassification. And so it's very important to highlight that. Next. I think these next two things are critically important too. While the majority of studies show that African American men are more likely to die by suicide, while African American women are more likely to attempt suicide, recent research has observed that Caribbean Black men in the U.S. have the highest attempt rate for the African American community. And so I think this just shows that there's subgroups even within the population that we need to look at. And it doesn't matter if you're looking at African Americans, if you're looking at Hispanic Latinos, Mexican versus Venezuelan versus Colombian. There's some special nuances that exist within those groups that may predispose them to suicide or other mental health or emotional challenges, and how they would go about seeking help for them. And then firearms is something that we use more often than other populations. You see nearly 50% of suicide deaths occur through the use of firearms. Almost 30%, a third of those is through suffocation within African Americans. Next slide, please. So this just shows you some trend data. Unfortunately, it doesn't matter what group it is, it's going up. And then you see the disparities for certain groups. American Indians, number one. You have Hispanics and Blacks, they're lower than whites in the overall, but the trend is still the same. And that's what we want to talk about today is how do we create a trend that goes down instead of up. Next slide. Past year, those who just had suicidal thoughts or suicidal attempts. Now, this is where things begin to shift a little bit because as you see, African Americans, Asians, as well as the Hispanic, Latino, Latinx populations, they are not too far behind in the thoughts of suicide, and then the attempts, they actually are in excess over. And so I think that is alarming for a couple of different reasons, but there's one thing to think about, but the act upon it is another thing. And so having some discussions about why are we attempting more than other groups is something we want to speak to today. And then next, and then this looks at our youth. And when you look at the youth, again, certain groups are higher than others. The Asian Native Hawaiian is actually higher than the overall US population. And then you see that the Hispanic Latino is about neck and neck with the US population for those considering the attempting of suicide. When you look at the actual who made a plan, again, the Asian, Native American, Native Hawaiian is in excess of the overall. The Hispanic Latino is about neck and neck. African Americans and American Indian, again, they're about neck and neck with the overall population with the suicide planning. And then at who actually attempted suicide, unfortunately, most minority groups except for Asian actually are higher than the overall average. And then last but not least, suicide attempt requiring treatment. Again, you see minorities fare higher in this category versus other groups. Next slide, please. So these are some of the risk factors associated with suicide. And so looking at some of our family dynamics, looking at how we value our culture, looking at being hopeful, and looking at being able to access services and things of that nature are factors that we're going to talk about today, but we wanted to highlight what the literature has in its regard. Next. Yeah, we can share these slides with you all. I see the chat going. Please, we will definitely get those out. And then protective factors is being able to have access, having a good family supportive environment, being able to develop skills to manage one's own mental and emotional health, and then having cultural appreciation are core protective factors that, again, we'll talk through today, but we want to make sure that we highlight as important indicators for helping us navigate this issue. And so I believe that concludes the slide presentation, and I will turn it back over to you, Alice. Oh, I forgot prevention. This is CDC's recommendations for prevention. They give core indicators, and then there are sub bullets underneath, and we'll just let you read that at your leisure. We just want to make sure that we put that there. Thank you.
Thank you so much, Calvin. Very well said, and we're very well put together. So when we start having our panelists talk, we ask that all of those who are on the webinar to please put any of your questions in the chat box. David will be monitoring the chat box, and he will chime in when he feels it's appropriate. So let's start talking, our panelists. Tina, what would you say after hearing Calvin's presentation here? What are some things that you would like to add in to some of the challenges that people of color are experiencing when it comes to suicide and suicide prevention?
Keeping conversations going Obviously that's what I do each and every day, but the value of it, it's invaluable to keep the conversation going, because it allows people to say it's okay to talk about it. It allows people to share with others who are thinking, what they're thinking. And it just allows that door to be opened a little more, and it allows to normalize the fact that you're not crazy and you're not unprayed up. You have you have something that we can talk about, that we can help. So I think more keeping conversations going.
And I think also, Tina, with your radio show that you have, that have been, David and I and many of us on with the Indiana
Yes.
Suicide Prevention Network have been guests on, is that you allow a platform or an opportunity for people to share their thoughts, their experiences, so that we who are in the prevention field can have our initiatives be more upstream. Instead of assuming, let's hear from the people in which it's affecting. So thank you so much for providing that platform to WTOC and their community involvement of making our communities mentally well.
Thank you.
Javier, what about you? How do you see our Latino brothers and sisters being impacted by mental health, as well as, more importantly, during this time of COVID? Unmute yourself, amigo.
Thank you.
There you go.
Yeah.
Go ahead, Javier.
Can you hear me now?
Yes, go ahead.
Definitely, the differences in culture and behavior are part of who we are. And as we listened before, there are differences in every culture. And the Hispanic Latino community specifically, as you asked, is a very cohesive, family-oriented culture. And historically, we also have some of the same things that were listed that prevent us from seeking help. And one of the things I think that is very significant in the Hispanic Latino community is the shame of shaming first the family with or recognizing a mental illness, especially depression, that is one of the most common causes that will lead you to suicide or suicide attempts. And so, because that tells other people, especially the family, that we are not happy. See, and we are supposed to be happy. We have a family. We have a connection to our extended family in our countries of origin. And we are now here working to support them and to help them too. And so there is no fairness from the patient perspective to not be happy. And so that delays very often the consultation process or the denial. So very often we have to go further and ask specific questions about how they are doing. Are they, screening for depression or any other mental illnesses? I think in these times, as we know, not only chronic conditions or mental conditions predispose to suicidal thoughts or ideation or attempts or suicidal itself, but other social determinants of health and pressure. Right now, we know many people have lost their jobs, and finances are pressing our families, and that brings to a sadness and desperation, hopelessness. Hopelessness, I think, is the most important word that we need to recognize, that if we are hopeless, then we don't see the light ahead of us. And so that's when we have to counsel them, advise them, show them that there are other ways to solve, and that prevention, and connect them not only to resources in the community, but also at churches and friends and family and providers, and giving them the sense of belonging and that they are not alone in this one.
Very good points, Javier. Being full-blooded Latina myself, I definitely concur with everything you have said. Religion, faith, it has a big impact on those in their help-seeking behaviors. It's often the time in which we are to talk to our ministers, our priests, our pastors, when it comes to our mental health, where in fact many of us need to go to a professional to meet the needs of our mental health. Thank you, thank you. Deanne, what about you? What do you have to add here?
First off, I want to be clear with what I say to Javier, to Calvin, to Alice, to Lynn, the product experts. I'm in communications. I'm a communications person. I am not a product expert in this area. My father was a psychologist, as Lynn knows, and my wife is a clinical social worker. So they are the product experts. But there's a couple things that we noticed that led us last year to stop the music across all of our brands on World Suicide Prevention Day. And what we noticed was there is a growing amount of the rates were growing across all of our brands. They were growing among teenagers, they were growing in the Latino audience, and they were growing in the African American audience. And those were all the brands that we represented. So that's why we chose to go across all of our brands. And then it was a learning experience. My wife has often said to me, in the African American community, part of the problem is a lack of communication in the family, to being open to talk about mental health in the family. It's uncle such and such, you know he's crazy, keep your kids away from him, let him go in a room, all the other things that, and people don't have open discussions about challenges people have in the African American community. And for me, as we have a regional Mexican station and a Telemundo TV station, I've started to see that a lot of those challenges in the Latino community are not only there, but they're there on a larger scale. Because in the Latino community, it's almost don't say that. That's a sign of weakness. And it was interesting, one of the emails or texts we got during Suicide Prevention Day to La Grande, our regional Mexican station, was a young teenage girl who said that she was having thoughts and even to the point of attempting. And her mother had taken her to church so that their priest could pray for her. And she realized that she needed to seek professional help, larger than being prayed with the priest at the church. And she sent the email that she had sought professional help and that she was in counseling. And that's what we've seen in the Latino and the African American community. I can only speak from a communication standpoint and from why we're doing what we've done and why we've done it. And those are some of the things that we are starting to see. And I'll be quiet as the product experts talk about specifics around that.
Thank you, Dion. Very important and critical points to some of the barriers and obstacles that people of color are facing when it comes to their mental health. Lynn, any contribution you would like to make? We can't hear you, Lynn.
Can you?
Yes, we can. Thank you, Lynn.
Thank you. Sorry. So I was sharing that as I listened to all the comments, one thing that the common denominator there that I think is really important to point out is making sure that as we look at what we can do as far as prevention and moving forward is the stigma, because all of these really kind of tie back to the stigma that there is with mental health overall, but especially suicide. As Dion just alluded to and others, people feel that you're weak. It's something to feel ashamed. And because of that stigma, not just within inside their own family and their own mindset, society's stigmatization of mental health and suicide really begins to create unmovable barriers for individuals. So if you're already dealing with depression or life situations that take you to the point of being, suicidal, you now have barrier stigma before you
I
get
think we
to
lost
help.
you there,
Put
Len.
challenges in there for connectedness. And can you hear me?
Yes, we can now.
Hello.
Yeah, we are. We're okay.
So I was saying that we, that stigma also creates that barrier for the connections that are necessary for people to reach out and to just acknowledge that there is an issue and that the help is needed. But it's changing the mindset of the individual as well as the family and society, because that is where the support system and the resources come into play. And if you are isolated from those supports, then overcoming this issue becomes even more challenging. So I really think that if we can begin to start changing the mindset and change the stigma that's associated with mental health overall, and in particular suicide, we can begin to look at giving individuals hope, and that hope is what will begin to work towards the prevention of this issue overall. So I applaud all the comments, because I do believe that as a clinician that is in the field and addressing suicide, this is one of the areas where, something's going on. You can see something's going on with the individual, but you can't help them, just like an alcoholic, until they're ready to say there is a problem. And so it is really important that dialogue begins even at the youngest, of ages. No one really looks at what we can do within our families, but there needs to start being dialogues within our families with our children at early ages about the importance of mental health. We talk about our financial health, our spiritual health. We talk about, the health of society, our academic health, but we don't talk about our mental health. So if we can begin to change that dialogue even at younger ages, I think that would be a great step. And again, just increasing overall awareness, which we see is happening with Dion, Tina, with you all that are here. Even every individual on this call is here because they're invested in this issue. And I think that's where we need to begin, at that community level.
Very good points, Lynn, and very well taken as well. When we talk about, minority mental health, we
Alice.
have to talk about trauma.
Hey, Alice,
Yes.
I did want to interject too.
Sure, go ahead, Calvin.
I think there's some basic foundational things that many families are challenged with. In some previous role, I worked with the Indiana Healthy Marriage and Family Coalition and have done quite a bit of trainings just with families. And some of the basic things about identifying the difference between a feeling, an emotion, or an act is a challenge for many people. And so when we talk about open communication, we're talking about the family dynamics. The basics of just being able to talk about feelings is a challenge. And so, part of the stigma or the shift that I really believe needs to shift or change within the context is families being able to talk about feelings. When I grew up, and I've heard it in many of my friends' household, they would say, what happens in the house stays in the house. And so the expectation is you do not go seek help outside of the house. But if you're not having discussions about your feelings and things that are going on with your house, with household members, who are you supposed to have that discussion with? And so I think, part of the challenge of shifting some of the stigma is also shifting some of the cultural values within the family context, where it's okay to go outside of the family and seek help. It's okay to have conversations about how you're feeling. It's okay to actually say, how are you doing? Not just how you're doing, how are you feeling? And I don't think that is happening enough. I cannot tell you the amount of times where we've done trainings and folks just said, I don't know how to have the basis of a relationship. I didn't even know that this is something I can do within the family context. When we asked them to have family meetings, it was the first time as a family they sat down and they actually talked when they participated in our program. And so if that's the context of many households, how many more would value or be able to shift some of the dialogue that's happening by having these open communication where there's an intentionality, not only just to have surface level conversation, but to have conversations of the heart. I think part of what's not happening is that we're not having enough conversations at the heart so the heart issues can get out. And so I really think, you know, as professionals, it's us promoting these types of conversations and dialogues and even modeling some of that. What we actually end up having families do is have a practice family meeting within that environment. And so they talked about things such as what are the family values. So we had them doing the family quest. We had them do I statements. You would be amazed how many people, they don't even know how to do those different component parts. And so when we talk about mental and emotional health and getting people to seek out help for this particular topic of suicide, you know, the basis of it is, can I get things out? And is there a vehicle or mode where we can get things out? And usually people will disclose to someone close to them before they can disclose to a professional. So I did want to share that because I think that's something that's critically important. And then I'm not sure if you saw the chat, but there is a specific questions about immigrant populations and some of the things that they are feeling. And I didn't know if we might want to touch that as well.
Hey, Calvin, or Alice, can I say something to what Calvin just said?
Absolutely. Go ahead, Dion.
So being married to a master's clinical social worker for 28 years now, there are reoccurring themes that I've heard over and over again that as we're doing more things with y'all that I'm seeing actually, as far as coping skills and having real discussions about substance abuse and trauma in households. And that gets to what Calvin's talking about, having an open discussion about different coping skills and discussions about substance abuse in households and about trauma that has happened in families and households that lead down the road to other things that happen because those real communication discussions don't happen. And I just wanted to add that to what Calvin had just said.
You know, I'm glad you guys both mentioned that because when you talk about people of color and communities of color, you have to talk about racism, you have to talk about trauma because it impacts their mental health. It impacts my mental health. What do you see as you know, the state of what's going on in our country, the many struggles that people of color are experiencing these days? How do you, as a person of color yourself, Javier, how are you dealing with your mental health?
One way for me is to do the things I love the most. So I enjoy going to work and see patients. I keep doing it. It was a little sad when we were not able to see them, but now we are back. You know, listen to the music, talking to friends and family, walking and exercising when possible. And so those things are the ones that help me. And just yesterday, we were having a conversation with a group of about 60 people. And most of them were saying doing what they love doing. There was only one person who said cooking, but that person is enjoying cooking. And so that is helping this person to cope with the stress of these times.
What about you, Lynn? What has been your experience in your business of providing assessment and counseling to your clients? What has been your experience in addressing the trauma, the racism, and how it impacts your clients' mental health?
For me, my experience, I'm a clinical level has been just really making sure that, again, that dialogue is occurring, because we have to process what we're thinking and what we're feeling. But before we can process what we're thinking and feeling, we have to acknowledge what has happened. And just taking, sometimes, you know, everyone has had many traumas and experiences in their life, some big, some small, but no matter who you are, going into that dark spot and going there alone can be very traumatizing within itself. Sometimes people have the ostrich in the sand syndrome. You know, something happens, they bury their head, they don't want to talk about it, without realizing the impact that that has upon you emotionally and psychologically every day, and then how those impacts begin to determine your behavior and your actions. So I always try to be the light, per se, for the individual in shining in on that dark spot, at their level, at their comfort level, which sometimes that takes time. It does take time to get to that person, because you're having to retrain them from years of, again, within their family, being told, you know, don't process your feelings, or you don't talk about their feelings, or, you know, some people grow up without family members ever saying to one another, I love you, or I appreciate you. So feelings, like many have said, have not always been processed at that family level. So trying to deal with the trauma and looking at that is something that's so new to them, just beginning to understand. But you have to embrace the feelings. And the only way you can embrace those feelings to begin to process what you're feeling is, you know, to just first acknowledge the trauma that you've had. One therapeutic technique that many people use is, you know, the journaling, writing a letter to yourself. Now, although it sounds, you know, very morbid for people who are depressed, I ask people, write your own obituary, because that's where you begin to start processing some of your feelings, things in your life, what you've done, who you are, what you want the world to know about you when you leave this place. Because just like the poem says, it's that dash in between the time you're born and the time you live where life really happens. So beginning to just process your feelings, and a lot of times that is just writing a letter to yourself or the person that hurt you. And that I share that, you know, that's something that you can do in private. No one else sees it, and no one sees it until you're ready to share it. But you're able to get that poison out of your system and begin to process some of those pieces in your life with trauma. So I think that it's important, again, you know, reiterating the fact that communication, and even communication at the family level, you know, I joke, and Dion knows my children and my family very well, because his wife and I are friends for a long time. But, you know, I tell this story about, you know, the importance of, you know, even teaching your children and within the family unit of discussing things. I remember when my son was 8 years old, he got in trouble at school, and, you know, I didn't spank him. I set him down. I made him process his feeling. I'm going to know what you did, why you did it, how you felt about it, how you feel about it now. An hour later, after making him process his feelings, he looks at me and says, Mom, can you please just spank me and get it over with? So, but what that did, it taught them how to process and understand your feelings. And so I think when we look at things from a clinician level, one of the first things we need to do is remember the very essence of what makes us all human, and that's our ability to feel and connect those feelings. And I think that that's crucial in any therapeutic setting. Even something, you don't have to be a trained clinician to do that. You know, like Calvin said, how are you doing?
Mm-hmm.
You know, but how are you feeling is always important.
Right.
I think something one of us can adopt. Just leaving out here today, we're asking people how you're doing. Don't ask them how you're doing. It's how you're feeling, and that's the first step in any dialogue.
That's all very good points, Lynn. Thank you so much. Calvin, how do you think or believe we should, put together the assessment questions when we ask our Black Latino brothers and sisters on their trauma and their risk factors? How do you think we should present those type of questions when trying to help someone that we feel maybe suffering in silence?
Well, I think a few different things. I think, one of the things that we really need to do a better job of is having focus groups with a plurality of different Hispanic and Latino groups, so we can get at questions that appeal to all, or we can really segment things out. My understanding, a lot of the mental health assessments currently, we say that they're culturally relevant. However, when you look at the history of how they came into being, those questions were not necessarily piloted or vetted with the people from that population, nor were the responses to those questions vetted. I always think about the public health questionnaire where it asks inner city folks about a supermarket. Well, we know up until maybe the last 5 to 7 years, supermarkets were not downtown. So people answered the questions, and you had people from diverse backgrounds answering the questions, but none of the responses were applicable to their context. And so you got a hit or miss response because the assessment tool itself was not vetted within the community. And so I think, the first thing that has to happen is, if there's a template that already exists, you have to vet it within that particular community, not only for the question itself, but the responses or the selections for which you can respond to. Because it's not just the questions, it's also the answers. Because the way that we do our assessments oftentimes is that we give people choices, but it may not be choices within their cultural context. And so it is very important to get an understanding of what the cultural context of the groups that we're reaching out to. Otherwise, what we can do is misdiagnose. We can mistreat individuals who's coming to us because we have it within a social context of the majority and not the minority. So I really think vetting it and also paraphrasing, making sure that whoever the client is has an understanding of not only the questions, but also the responses that's attached to the questions. And what we may find is, if we have them paraphrase, we may find that, hey, they either don't understand or none of these match where they are. And if that's the case, that means we need to do something different.
Hey, Alice, can I come at this from a different angle?
Go ahead, Dion.
So I want to come at this a little bit from a business angle, because we see everything going on right now with racial tension in the country. And I think that has a tremendous effect on people mentally. But we've also been locked down for 7 months now. And I oversee I work with, because I don't like to use the word oversee or boss or anything like that, but I work with several different markets and several different projects throughout our company and other companies. And yesterday I was on the call with someone who is a high-level executive in another company, and we were talking about that now what we do part of the day are counseling sessions. Because, and you got to think about this, there are some people who have been locked down for 7 months that are single, don't have a dog, don't have a significant other, and they are seriously, there's signs of depression and other things going on that they don't know. I mean, it's just, and they don't see an end to it right now.
Right. There's a lot of lonely people in this community, in our community, and in the state.
Yeah, so that, and then you take everything else going on in America right now, and you mix that all together. I mean, we're going to do something we've never done on our airways starting September 1st for the whole month. We're not only going to stop the music and have that discussion that we had on September 10th from 10 o'clock to noon or 1 o'clock across all our brands, but every single day during the month of September, we're going to talk about depression, how you recognize it, exercises and steps and other things you can do to help process things through that process. Because there's a lot going on with people right now in this state. And I just wanted to say, from the other side of that, from the business side, from the COVID side, You've got people, because work was a way to a lot of people, that was their interaction. Their interaction with their friends, their interaction to actually touch and talk to other people. So you've got people who've been locked down for 7 months who haven't had any real interaction, and they have things going on mentally that they've never had in their life, and they're trying to figure out how they cope and how they function through that. So I just wanted to add that to this discussion.
Very valid point, Dion.
Alice,
Sure.
and to add to Dion's point, 5 days a week. I don't do music. My show is talk. It's all talk, and I want to underscore his point about not being a product expert, because by no means am I or are we here at the Indianapolis stations of Radio One, but I do talk to people every day, and I do listen. And it was interesting, Dion and I talked about this a lot. We all talked about it, watching the dynamic that developed when we opened up that day on September 10th of 2019, when we just opened up all day. And the dynamic was absolutely fascinating, was absolutely amazing. And it was kind of like the dynamic that I see and hear daily from certain callers who are simply looking for affirmation, it seems. I mean, again, I'm not an expert, but it seems like they want to be validated. They want to be heard. Sometimes you question, why do you want to be out there on the airwaves every day with your opinion or whatever? And then after a while, you don't question anymore. You start to realize and you start to understand that this is that person's outlet. So, circling back to what, how do you cope with like, as you said, Dion, 7 months of being shut down, 7 months of isolation. A lot of people that 7 months of isolation, it's in my paid observer, because I'm a paid observer, again, not a product, but a lot of people, that's their existence, pandemic or not, because that's the vibration that I get each and every day. And in some ways, you kind of have to talk them through things and say, well, why do you think this? Or what? It's just the engagement. They love people love the engagement. And so somehow, as we go into September, Dion, that's a good point. We've got to find a way to effectively, as broadcasters, we are broadcasters, to most effectively use our voices to get at that. Maybe, as you say, Dion, identifying depression and talking about it, we also need to use our voices to help, as you talked about, Calvin, solutions and things of that nature, because a lot of times people want, one of my friends who is a psychologist joked with me one time, and she was saying that people don't want to be racist. People don't want to be, they don't want to be against culture. They want to join, they want to help. But what they really want is the book. Where's the book? Give me the book so that I no longer will be racist. Give me the book so that I can be sensitive, and give me the book so that I don't have any inklings of mental illness, whatever. And it's more of a process than a lot of people want to believe. So I'm hoping that that is a good opportunity, Dion, that throughout the month of September that we can help with the process, help people understanding the process. And help people understand that they are heard, and help people understand that of course you're important, and of course everything about you is valid, that you're validated. So probably a long way around a short question, but that was just my 2 cents that I wanted to add in.
And Dion, I would also say that with COVID, it has created some economic trauma that people are still trying to reel from, because people have lost their jobs, or they've gotten their hours cut down. And in addition, I have to deal with people longer periods of the time of day that I traditionally did not have to. And so I'm having a multiplicity of inputs of frustration, agitation, anger, sadness. And there's not necessarily a good indication that there's hope in sight. There's relief anytime soon. The job market is not what it used to be. And then for those who are in disparate groups like we're talking about, where there's an overrepresentation of minorities in hospitality service industries, and they are the ones that are mostly impacted by retail stores closing down, or they're limiting their hours, and because they're limiting their hours, they're limiting the number of hours that people can work. And although we have a stay on utilities and rentals, not putting people out, the reality is that is shifting. And so, you know, part of what's promulgating some of the suicidal ideation is, how am I going to support my family in lieu of everything that's going on? And then we've also had calls where people say, I'm trying to get into the healthcare system, but I can't get in. I can't talk with anyone. And so, you know, part of the challenge is that access. And then the other complication is we emphasize telehealth, but the capacity of some of our groups, like our immigrants and our refugees, some of our lower income African Americans and Hispanic Latinos, Asians, they don't have the infrastructure to do telehealth. And so there's a lot of different complications where what we have to do is help remove some of those barriers by creating opportunities where they can come on site at different places to access the telehealth and or access a health professional or access some of the services that's needed, or provide linkages to these, what they call mobile job fairs now, virtual job fairs, but pointing them in the direction that, you know what, there is a ray of hope. You just have to look for it differently. So how you used to look at it in times past, you used to be able to just go to a job fair, you used to be able to just go online and do blanket Indeed resumes. You may have to do a couple other steps, but helping folks to navigate that there is economic trauma, but there's also some other economic solutions that we can link you with. And whether it's a rental assistance program, whether it's a utility assistance program, there is some help out there for you.
Hey, Calvin, you raised a really good point that I want to jump on real quick to the experts on here to realize our first step with our EAP program is telehealth, right? And we've had a couple of our older employees that their battle is Zoom and Teams and where we're going and stuff. And they've had a challenge with telehealth. So I just say to all the product experts on here and stuff that to be aware sometimes of what the best way to work with certain people are. Because we even went to the point with a couple of employees where we said, you know what, EAP doesn't cover this. We're going to extend this coverage for you to see someone in person, because that was the best way for them to communicate with everything going on around them. And the fact that they have been locked up for 7 months, I shouldn't say locked up, but that we've been on lockdown for 7 months. And telehealth wasn't necessarily the best process for them. And I don't know if Lynn or Calvin or some of the other product people want to speak to that, but that's what we started to see. And we literally expanded some benefits past the AAP because that was the first step they were telling them to do. And it really wasn't the best process for those individuals.
Yeah, and Dion, my question to Calvin just kind of just dovetails off of that. Virtual fatigue. You know, a lot of callers they're expressing virtual fatigue. And so it just kind of dovetails off of what Dion was saying.
And that's a Lynn, Calvin, Javier. I mean, that's a product knowledge person question, I guess.
Yeah, for us, it's the same. We have to individualize each patient. We have an initial interview, and then we assess the need to see the patient in person. you know, and so we are advocating for people to be able to come and be examined and have a real time and physically present visit as usual. So that is something that we have to decide, and with the patient, if we don't feel comfortable, or they will feel more comfortable coming.
Lynn, you were going to say something?
Yeah, I was going to say, I see in the chat that someone mentioned the doxy.me, which is a free telehealth that people can use. So you may want to check your chat. But in addition to that, and we have ran into that, and I work with a lot of clientele base from Department of Children's Services. So like Calvin said, there are individuals that just don't have the resources to do the telehealth or may not feel comfortable. There's also that cultural barrier at times, you know, with trust level, you know, so it's necessary. And what my experience has been is for those individuals, first of all, I just want to applaud you, Dion, because what is important that everyone do, whether it be suicide or any mental health or just in individual relationships, is listening. And it sounds like you there have listened to the needs of the individuals, and that's what we all need to do, is listen. So if you do have an individual that is not comfortable, if there's a trust level, if there's a language barrier, whatever it is, it's important that you do all you can, which is what we do with my company. We just make sure that we're being as safe as possible. We do the one-on-one if we have to. Sometimes it's even better to do the telephone. I know with health, you can't always do that, but with the mental health, you can. People will more than likely still have a phone, and a lot of times smartphones, but if they're not comfortable with doing the face-to-face, even through the phone, we're able to just do telephone, where you still can hear them and listen, and they need to be validated, their feelings and their needs. And sometimes it's just a matter of connecting them with resources that they're comfortable with, or you know, things that are out there for them. So I would say that has been how we have addressed that need and that issue. But the first thing that we do to address that, and I think everyone on here that deals with the clientele base, as well as you dealing at that corporate level, is just listening and finding out what their needs are and what they're comfortable with, because that does begin to validate and build that trust, because you have to build that trust level with anybody at any level. So I think that's important.
So this would not be a webinar if we didn't have tech issues. Alice lost all internet on Purdue Fort Wayne campus, so I'm going to step in until she can hopefully get back on. So we've talked a lot about mainstream minority populations in America. What are your thoughts about dealing with suicide prevention with immigrant population? Calvin, you want to start with that one?
Sure. I think there's a couple of different factors with immigrant populations. One is just acculturation and getting populations to become more familiarized with our system. But I think the biggest challenge is that the way that our system is currently designed, it does not lend itself to provide support in these COVID conditions, because a lot of immigrant populations, they can't take advantage of the rental assistance program. They can't take advantage of some of the health care. They can't take advantage of some of the food things, because they ask for ID. They ask for things that document them as citizens, and if they are not, they're excluded. And so they're forced to have to do things such as work in conditions that normally anyone else would not. I think about the outbreak that happened even in our state with, I think it was Tyson's Food that was up in the Logansport area, where you had hundreds of people during the middle of the outbreak who were still working at the plant, and they had a outbreak. And most of those were immigrants who, when you do a deeper dive, they felt like they had no other choice, because the only way that they can get resources into their family to pay their bills, feed their families, was to work. And so I think there is a stress, but I also think there is a opportunity for philanthropy and helping to connect our resources. I know the faith community has arisen a great deal to provide assistance to immigrant populations and addressing not only the economic condition, but also to look at the whole acculturation process with depression and anxiety that's associated with being able to provide for their family. A lot of immigrant population just want to come and live and be able to grow up in a healthy and well environment, and not being able to have provision for families is something that is problematic. The other thing is having someone that speaks their language. So if you're not able to access the service, and then the healthcare setting has to use a language line for you, it creates another barrier. And so I think part of what would be helpful is to be able to employ or have real folks that can actually speak the language of those who are reaching, because it helps to promote trust. It helps to promote better connectivity so you can treat them in the best manner possible. But I'm going to stop and give other panelists an opportunity to weigh in on this subject matter.
Definitely. I agree with all of these statements. In 2002, and then repeated it again in 2016, I conducted a research in the Hispanic Latino community, and access to healthcare was significantly limited due to the cost of the services, lack of health insurance, no knowledge of the language, so language barrier, and then transportation, fear of the system, not knowing what was available, and others were the main barriers that we identified, and they repeated again in 2016. So despite of all of the efforts that the community serving organizations, even the government, local governments in not just in central Indiana, but in other counties, because the Minority Health Coalition had been working for years with different counties, Indiana Latino Institute, the State Department of Health. We have partnered in many endeavors to help the access to healthcare, but it's still present. And so all of those, are still the main reasons why the impact in not knowing the access. It doesn't matter if they have no insurance of done, because if we don't know how to access these services, it's always asked, do we understand our health insurance policies? I don't. And so this is something that if you don't speak the language to start with, and I'll say, okay, you have insurance, where do you go? Where do you find those things if you don't have somebody to help you to navigate? And that's one of the first barriers that the system have. It's a system that is difficult to navigate. People are afraid in some instances. And not just afraid, because we have so many immigrants that have all of their documentation, but they are afraid of mistreatment at the sites. And that's a very common thing that we need to create awareness in our services, that the front desk is the telephone, and front desk are so important, because that is what makes you feel welcome or unwelcome. And so that is a very important thing that we have been emphasizing for several years. And now we are trying to let our community know where the services are. We have put together years ago, and now working on the new edition with the Indiana Minority Health Coalition, a directory, health directory for the Hispanic Latino community in Spanish. And so those kind of things help the community to know where to go, and also knowing that there is an effort to welcome them. And my advice for several years to practices in health subsystems is, do not have to create a new clinic for Hispanics. Just have to adapt it, front desk that is bilingual, a MA that speaks Spanish, and hire a physician to provide the services. And so that already makes a whole change and then with the appropriate delivery of services, which is the other barrier, is even if we access the health services and there is no one, as Calvin was saying, who speaks the language, so many things will be missed, especially when we are talking mental health, because those are even more subtle. And you have to know the language. You have, as somebody was proposing, we have to know how to paraphrase the standard questionnaire questions. We need to go culturally to the point and ask how they have been feeling in the last 2 weeks. And then, or ask more extended questions like, how is the family doing? And that sort of things. And then obviously being able to communicate is what will help us to have better outcomes. So I agree totally with that. And we need to find those resources and make them available to the community.
So talking about language, I want to kind of redefine what we mean when we say language, as opposed to what we were talking about now. We had a couple of comments in the chat that are related, but leads me to a question. So one individual said that working with prison population, as far as people of color, when they're asked to express their feelings, sometimes they lack the verbiage and knowledge of emotions. Many of the men know little about feelings and how to express them in words. And then someone else said something similar as far as working with teens, and that they worked with 2 young men last year who were in the midst of profound grief, but didn't even know what the word grief meant. How do we educate individuals, whether it be men, whether it be individual men that are individuals in communities of color, or just individuals in general, about what some of these words mean, not necessarily from the English versus Spanish versus a different language perspective, but what these words actually mean, how we define feelings. Anybody want to start with that?
I think
go ahead.
I wanted to say something Lynn said again, and it's the relationship. It has to be relational. You have to gain the trust of the community, and in my case of my active patient population of patients, years ago, a father and 2 kids came into the visit. It wasn't, they were not saying anything. I did not receive a message, but it wasn't common. It wasn't the usual that the father will come with the 2 kids, might come with 1, but not the 2 kids. And they were very quiet, no words. And so I had to notice first that there was something different going on, and then explore. Once I explore, I have the answer. Mom has been killed during the weekend. And so just imagine the sadness that these kids were going through. It wasn't going to be mentioned. And so we have to be, exploring and welcoming people to express how they are feeling and how is the family doing. To my students, I tell them there is no visit with our patients if we don't ask, how's the family doing? And people know it's not just a hi, how are you? No, it means how is the family doing? It's a real question. It's like if you still ask me, how are you? And I know you, I will tell you how I am. I won't just say, hi, how are you again? It's a greeting, but not a question. And so in some cultures still, or if we are not acculturated, it is, we have to ask.
Okay.
And I think it's important too, because it's almost like using reverse psychology. Just like what was stated, you have to ask how they're feeling. So they may not understand what the word itself is by definition, but if you, again, listen to them, you ask how they're feeling, and you listen to them, then you can connect their feeling to that word, and that is the way to begin to help them to connect what the meaning of grief is, or anger, or depression, or whatever it is they're feeling. So I think, again, it does start with how are you feeling, and listening, and then educating them based off of their response. You're feeling like this, and that's what this means, so that moving forward, they're able to articulate their feelings. I'm sorry, Calvin, go ahead.
You're okay. You know, I'm a therapeutic foster parent as one of my other hats. And part of what I know that what I really try to do and what we're also trained to do is help them identify emotions. So sometimes we use the emojis. You know, a lot of the young folks, they're very familiar with the emojis and explaining things based upon the emojis, and then connecting that to, it could be a music video, it could be a movie that they've seen, a television show where it actually plays out, because it's hard to wrap your mind around a concept that you're not familiar with. But if you could see it modeled somewhere where someone was sad and grieving and stay stuck, or someone was frustrated or angry and sad, and you can match the emoji with something that is practical, it helps for understanding. I have a lot of kids, they tell me that they do not understand what I'm saying because the words are too big. And so what I end up doing is try to provide a practical application or example. And it could be an Xbox, a PlayStation, it could be something that they have on Instagram, but I really tried to connect them with the concept based upon the sources that they currently are using, because they would remember it better. But I think navigating the whole emotional spectrum can be a challenge. We just have to be intentional about identifying the continuum, where it is, and then helping to provide those definitions in those practical manner.
I'd like to say that this is a serious thing with people understanding trauma. Especially in America right now, with everything going on from COVID to race relations to, and I'll give you a specific example because people would consider me to be a relatively successful person. So everybody talks about the 19 pounds you pick up from COVID. I think I had the COVID 30. So I was looking for ways to lose weight, to exercise and stuff. And I'm watching the show and they're like, well, swimming gets everything engaged. So I go and I look, and the Fort Bend Y is closed, but the Fishers Y is open. So I go online and I register for a lane to go swimming at the Fishers Y. And my wife works for Community, and I drop her off for her 7 a.m. shift at Community, because I'm like, sweetheart, I'll take you there and I'm going to go swimming. I drive up to Fishers, probably 6:45, 6:50 in the morning, right around there, and I have a 7 o'clock time to swim. And I'm watching all these people get ready to get in the pool, and 3 people walk in with me because it's right the time to start. There's an older white lady, 2 white gentlemen, and me. And I'm the only African-American person in all these lanes. I watched the 3 individuals go to their lane to get ready to do their swimming. And I watched the lifeguard pop off the stand when I walk in and start running over toward where you get in the lane.
Oh yeah. I'll just take my condiments out.
With a clipboard. And I mentally start going, I just want to swim this morning. Here goes all this stuff again. Here comes all these things that are going to happen. Because I walk in as the one black guy in here. She comes running with the clipboard. And the lifeguard comes up to me and goes, are you in lane 3? And I said, yes. And she asked the other people in front of me as she's getting to me. And I said, yes. She goes, good. I ran 5 people off of your lane before you got here. And I said, thank you. But I was all in this state thinking that I was going to go through this whole situation that you go through, unfortunately, no matter what your status is as a Black man in America. And I was saying the story to my wife, and she was like, talk it through, talk it through. And I'm like, no, I'm done. She goes, no, talk it all the way through. Because she goes, that was a traumatic situation. And the why you had your guard up was because you've been through other traumatic situations. You need to talk this all the way through. And I think whether you're talking about somebody in a prison, whether you're talking about somebody who's in going through foster care, whether you're talking about identifying traumatic situations and how they affect you is something very real for people who are lay people, that they don't understand what's going on to them sometimes and how that's a traumatic situation to them and how it affects other things and how they affect other people. If that makes sense, what I'm saying to Lynn and Calvin, and I just stop for you all as product experts.
Oh yeah, it definitely makes sense, and I think with the process that you described is really teasing out what has happened from what they felt when it happened, because most people can really give you the event and list you the details of what transpired, but connecting how they felt with those details is where things become challenged. And so I think, you know, part of what we have to do is walk them through what was it that made you angry or made you sad, or what were you feeling when XYZ was happening? Because, you know, things shift depending upon the context, but I wholeheartedly agree with what you're saying.
And I'll add to that, the inability to actually connect that, like you're saying, Calvin, I think is what leads people to a lot of violence and anger and, you know, depression, because they don't know how to process that. Instead, we internalize it and it becomes part of our subconscious, which becomes part of our behaviors and our normal reactions, which is exactly what you explained, Dion, is that whole scenario was the internalization of your trauma. And how it's impacted your thought process and the way you process things and the first thing and reaction you had. But I think it was important that you had, you know, Angela there, and it's important that we are all those individuals that can help people identify those feelings and understand that trauma, internalization of that trauma does affect our outlook and how we deal with it, but more importantly, how it affects our mental and emotional health. And I think that's where we lose the connection and people begin to drift off, because people don't realize how our mental and emotional health, and people don't realize that emotional health is even something that's important. So being able to connect those dots like that can guide you to have a better outcome, as opposed to internalizing it. That internalization becomes poison, which in turn turns into depression and suicidal ideation or violence or broken relationships. And then the cycle becomes not just repeated, but when we have that in families, we see the cycle become generational. And that too is something that's really important, because we see generational. And we all know mental health can have a genetic component, but when you have those little nuances and cultural, you know, norms and values that impact how we process things within families, within our communities, within our culture, within society, we begin to see that cycle, and it does become generational, and then that makes it harder to break that cycle. So good point. I'm glad you shared that, because it is about self-awareness, which is kind of where we all need to begin, whether we're the person on one side that's helping the individual who may be suicidal, or whether the person that's going through it. It's that self-awareness and always being best friends with me, myself, and I. Knowing yourself, knowing what you're feeling, and being able to share it. So thank you for sharing that, Dion. That was powerful.
Yeah, Lynn, I was going to say, I'm so glad that you stated that, because we as practitioners oftentimes overlook our own mental, emotional state and being connected to it. Because it also impacts how we engage others. I mean, we all are very familiar with ACEs, and many folks who are practitioners, they have high, mid to high ACE scores as well. And so I really think it's very important for us like they do in the airline industry, is they say before you put the mask on someone else, you have to put the mask on yourself. It's easier for you to treat someone else when you have first been treated yourself. And so I think, you know, to the extent of what you and Dion has just shared, is critically important to do. I think about the book of the 5 love languages as well. Knowing your love language helps you to communicate with others how they can communicate with you, but also it helps you begin to identify that language to others so you can display it.
And you know, we often share and tell people, and we try to educate people when it comes to your doctor's appointment or communicating with your doctor. You have to be an advocate for your own health. Well, you have to be an advocate for your own mental and emotional health as well. And like I said, if you can't help anyone else if you are not, you know, healed or at peace. You know, I jokingly used to tell my husband all the time, it's a stressful day, you know, I'm gonna go have a mental breakdown for about an hour. If I'm not done in an hour, come get me. You know, I may have gone too far, you know, but that was just a joking way of saying, yeah, it's been a really great, depressing, stressful day, but I need to go process so that you can take care of your own health. So I encourage everyone on this call, because we're all out there helping. We're here on this call because we're passionate, and as part of our work, we are dealing with suicide and people that are experiencing, you know, depression or whatever mental or emotional health they're going through. But it's important that we are taking care of ourselves as well, because we're not going to be able to help anyone if we are not first addressing our own issues. So I think that is really important, and it's one of the most healthiest things you can do to help other people, is to take care of yourself.
So we've touched on a lot of the questions that have been posted throughout the presentation. I want to make sure we hit one more. We've got about 5 minutes. First, I want to apologize or say that Tina had to run off. She's got a show coming up and she needed to prep, but she wanted to thank everyone for the great questions and discussion. And so first I want to give Dion a quick question, and this will take about 30 seconds. Someone wants to know how they can listen to your radio shows online, and they'd like to share that on their Facebook page.
You can go there. You can go to 13 WTLC AM and download the app, and you can listen on the app anywhere. It's also on TuneIn on the app as well. So from our app, you can stream us anywhere in the world.
And then I want to make sure we hit this last question. It'll probably be our last one before we run out of time. So this comes from Evansville. Some individuals that are QPR gatekeeper trainers down there, and they are white, predominantly white women, want to know how to have the right conversations with different cultures by addressing the areas that stigmatize, such as the what happens in our house stays in our house. Is there a good resource or suggestions that you can make to find out what cultural barriers they're facing so they can address those issues in trainings to make sure they know how to break down the walls to get people to seek treatment? Just knowing that they're aware of those barriers, they feel will at least let the individuals they're working with know what obstacles to treatment might be there in getting help. Any thoughts on that?
Okay, I'll take it. So I think that when you have that cultural barrier, we go right back to the whole trust issue. And it will take a little bit more time. But again, I think that is acknowledging that I understand that you may not feel you can trust me, or that I may not understand some of your cultural values or cultural norms, or understand where you're coming from, but I'm here because I care. I think when we take that human approach, that breaks any barrier. It may take longer, but just being human and showing sincerely that you care. One of the worst things you can do, and you can be of the same culture, is to have an approach that is so book knowledge. Nobody wants to feel like they've been to a counselor and all they did was opened up a book and said, okay, step one, you know, is I ask you this question, and be so rigid and so unconnected. So you have to make that connection. I know there's a risk, because I did see in the chat about in the prison system, there is, a risk of showing your emotions or that trust. So I do realize that that is a barrier, but when you're having, or if you have those one-on-one times, I think it's important to just acknowledge to that individual that, you're here because you care. You're in this position because you care, and you're not looking at where a person has come from, the mistakes they've made in their lives, the choices and decisions, but just getting across to them that you're there from a very passionate human perspective will begin to build that trust with them. And I'm glad that that is brought up, because Calvin and I both sit on the Help Forum and sit on the recent Indiana Health Disparities Task Force that was designed to address the COVID disparities. It was at the request of the Indiana Black Legislative Caucus, but that task force will continue on, and one of our subgroups is the prison population and addressing health disparities and mental health disparities within the prison population. So that's something that I'm personally going to take note of making sure that we are able to provide those who are in the prisons working at that level with some cultural competence training and how to break those barriers. So I'm glad that that question was brought forth, but I still say just taking that caring approach, which is why you're here, which goes right back to our very beginning of listening.
And to your point,
practice. I'm sorry. Go ahead.
I was going to say to Lynn's point, one of the things that we're also doing is developing a program for social supports, because what we recognize is that when people re-enter society, their families and friends, they have no idea about, one, what it means to be locked up 8-10 years, where you're told what to do from the time you wake up to the time you go to sleep. Then you're released into freedom. You're expected to then live out an unstructured life. But then two, there's probation fees, there's program fees. And so they already come out with responsibilities, but they have no job. They may not have a stable housing. And so there is just a multiplicity of dynamics going on that a lot of families and friends, they are just not aware of. But on the same note, we also understand that they're coming to families and they expect they're going to be eating their food, they could be drinking, they're using the utilities, they're using resources. And so we're trying to create, have families begin to think about a roadmap of help, and whether it is lining up felony-friendly, misdemeanor-friendly jobs, whether it's getting a budget together, getting a daily schedule together, but things such as that can help mediate and facilitate the transition is what we're hoping to do, so we can create whole families. So just as a addendum to what Lynn had spoken. Thank you.
Any other last comments, thoughts? It's 11:30. Maybe why don't we do this? How about in one sentence? Let's just go around before all of our panelists leave. One sentence. What the most important takeaway you think all of our participants should have as far as culture and the intersection in suicide prevention and just in work in the mental health world. Dion, let's start with you. One sentence.
Being a lay person, not an expert in your field, my one sentence would just be awareness. I think what a lot of people, and to the people in your fields, I say, a lot of people aren't aware of the emotions that how the emotion or some experience they went through is affecting them today. And because they're not aware of it, they're not open or acknowledged to talk about it. So that impacts them and they don't realize how it's impacting them. That's all I would say.
So let's change the question to one point to follow Dion's lead instead of one sentence. So Javier, 1 point for most important takeaway that you think all of our participants should have as far as culture and intersection with suicide prevention.
Yeah. Reaching out to our communities, letting them know we are there for them and at their service, and be welcoming.
Thank you. Lynn, same question.
I would say advocate advocate for your own mental health, advocate for the mental health of those around you, and advocate for reducing the stigma so that people have a safe place or feel safe in discussing their mental health.
And Calvin, I see you just put something in the chat. Is that your?
Yeah,
is that your
I
thing?
wrote it just in case time left us. But my whole thing is ask. The biggest thing we can do to promote relationship, to promote awareness, both for our individual selves as well as our clients, our patients, our community, our family, is to ask. Most people are more than willing to share about themselves, but a lot of times folks are not asked to do so. So I really believe that part, even with the cultural humility, it's us being humble enough to ask what is their culture about, what is that particular context about, and I can assure you most people will be more than willing to ask, and would rather do so than for us to assume what those thoughts are.
Awesome. Thank you all to our panelists, Dion, Calvin, Javier, Lynn, and Tina, who had to jump off. I think this was really dynamic. We had a large number of participants today, and we really appreciate your time. I want to remind everybody that our webinar next month will be on September 17th at noon. We have Indiana's own Silouan Green, who is a nationally renowned speaker on suicide prevention, trauma, resiliency, and a number of other things that will be doing our webinar, and we will have that registration link out shortly within the next few days. So thank you, everyone. Appreciate everybody's participation. Have a great day.
You too. Thank you.
Thank you.